hate to disappoint everybody, but we're actually not talking about post-surgical management of the newborn. I actually want to talk about the use of the laryngeal mask airway in neonates. We're going to be doing a workshop in just a couple, I guess about an hour, hour and a half, talking to you about how to do this, how to use this very important device. I feel sort of cheap as a neonatologist. Everybody else is talking about medications that are $1 million or something like that. This little device is $1.63. That's the price that my hospital is able to get it at. I think it ranges as much as like $10 based on your contracting. So this is very cheap, but this can be used to save lives. And that's what I want to talk about. So I want to talk a few objectives that we have is we want to discuss the development of the laryngeal mask airway, how this has occurred over the past couple of decades. I want to go over with you the current recommendations by some of the organizing bodies of neonatology like ILCOR and American Academy of Pediatrics and groups like that, supporting the use of the LMA in neonatal resuscitations. And then I want to review the data that is currently existing, talking about how we can use the laryngeal mask airway to administer surfactant. I think this is a very important development, something that's pretty exciting. And then I want to very basically teach the group here how we use this device to deliver surfactant. And if you're interested, you can come to the workshop later today, and I think we're going to possibly have a second workshop tomorrow to teach you exactly how to do this. So this scares me to death as a neonatologist, trying to intubate a baby. This is the most difficult procedure that we do probably. And it is one of those, you better be good at this when it's time to step up and do it. And no matter how many times I have done this, which is probably in the thousands by now, my palms still get a little sweaty. I still get a little nervous because I hope I can get the tube in. And it's interesting when you look at the studies that have talked about how easy or maybe how difficult it is to do this in real life. We have a first-time failure rate of up to 70%. That's been reported in multiple studies. And an adverse event rate of when we attempt to intubate these babies approaching 40%. 40% of the time, something might go wrong. This is emphasized in just a study that came out, again, last month, international group, looking at how good we are. And if you're a pediatric resident, do I have any residents still left here today?
They're sleeping.
They're sleeping. All right, I've got a couple. You've got a 24% chance of getting this right the very first time, okay? And if your attending lets you try to do it again, you're getting up about 50% or so. Somebody like myself, 64% chance of getting it in the first time. I think I'm a little bit better than that, but 64% chance. And if we try to do it multiple times, 88% chance of getting it in. If you look at all the centers that participated in this, look at their adverse event rate. A number of them had babies that had severe desaturations. A number of them, up to 50% in that group at your right, having adverse intubation-associated events, sometimes like an esophageal perforation or something really, really bad like that. So intubation is difficult. And as we begin to explore some of these non-invasive ways to take care of these kids, whether that's with non-invasive ventilation, or whether that's with some of these non-invasive surfactant strategies that I talked to you about last year when we talked about aerosolized surfactant and the LISA technique, and I touched on the LMA a little bit, we're going to have people who are becoming less and less capable of being able to intubate babies. So we've got to come up with other things that we can do to make sure we can save a baby's life. And that's where this $1.63 device comes into play. So let's talk about this. This is not a new thing. Okay, this was first published in the British Journal of Anesthesiology in 1983, where some anesthesiologists came up with this laryngeal mask. And actually, I think the story is he used it on himself first before he began to test it on people, and it worked. And it didn't take too long before this was then implemented into the neonatal world. So 10 years later, the first report came of using this in neonatal resuscitation, and they had a report of several babies that they used this laryngeal mask on, and you can see it was very quick to get this in. Looking at it really less than 10 seconds on being able to place this laryngeal mask airway and then being able to successfully resuscitate a baby as we see with that heart rate increase. So as this data began to accumulate, these governing bodies, the International Liaison of Neonatal Resuscitation, both European and North American group, said, hey, this is something that we need to get behind and begin to introduce this into our NRP classes and other resuscitation courses that we teach on taking care of these babies. And people need to be aware that this technology, pretty basic technology, exists in order to help us resuscitate babies in the delivery room. And so that's their statement. As always, more studies begin to follow once we have an organization that says, hey, this is a good thing. And so Cochrane Library has published a meta-analysis looking at these studies. I want to go through a few of these things with you that I thought was pretty important. They said that when you compare this to bag mask ventilation, so our old standard on taking care of babies in the delivery room, that the laryngeal mask airway is associated with less need for endotracheal intubation. Okay, you put that laryngeal mask airway and use that instead of using a bag mask ventilation, you're going to have less need to resuscitate that baby with an endotracheal tube. You're going to have more chance of success. It's also associated with a shorter ventilation time of nearly 20 seconds, and they judge this by looking at the APGAR score. If the laryngeal mask airway was placed rather than using the bag mask, that resuscitation was so much more effective, their APGAR scores were higher at 5 minutes. Babies resuscitated with the laryngeal mask were also less likely to wind up in the neonatal intensive care unit by half. Pretty significant difference they found when they started crunching all these numbers and doing the meta-analysis. Cochrane has also published a meta-analysis on comparison to endotracheal ventilation too. And they found that it's equivalent, okay? This device is equivalent to using an endotracheal tube in all of the measures that they looked at, okay? So equivalent device. There's multiple different brands in the market. And in a workshop, we'll talk about some of these different types of laryngeal masks. I want to focus on one that is a cuffless one, okay? It's a lot easier to use. You can see all those up there, but one, number 7 there, you have to have a cuff that you insert some air in to help it fit. But number 7 has a thermoplastic cuff on it that heat molds to the baby's larynx. So very, very easy to use. There's been one study that has looked at this cuffless laryngeal mask airway and compared this to our face mask. And interestingly enough, they found that this was so easy to use that 100% of the time, healthcare workers were able to get this in on the very first attempt. Compared to the bag mask, which, believe it or not, was not 100%. And if you think about that, in the delivery room, your adrenaline's going. Sometimes it's very difficult to get that seal, to get it in just the right place, to maybe use that mask exactly right. But the LMA, once that's placed, you know you're going to have a good seal. They also found that it was much more quicker, down to 6 seconds, in beginning to ventilate the baby, so faster than using the bag mask. And then they asked the healthcare workers that were involved in this study to just sort of compare the two. Which one did you think was easiest to use? And as you can see there, the group said the laryngeal mask airway was actually easier to use than what we have typically used in the past. All right, so let's talk about using the laryngeal mask airway for surfactant administration. And this is pretty exciting, I think, pretty exciting development. As always in neonatology, somebody says, hey, let's try something. And so this group did this in a couple of babies, and they said it actually worked. And in neonatology, we have this habit of doing something and then actually studying it later. And so that's what's happened over the past decade or so since this first attempt giving surfactant through the LMA. We began to study this. And so this group went and said, let's look at this in animals and compare the endotracheal administration of surfactant to the laryngeal mask administration of surfactant, and let's make sure this works. Well, it's equal. Okay, you give surfactant through the LMA, it improves oxygenation. You give it through the endotracheal tube, it improves oxygenation. But the LMA is much faster to place. Okay, I can do it with my eyes closed. You have fewer attempts in getting it in place, and it results in less of those hypoxic events, those desaturation events that we can sometimes see with endotracheal intubation. And so various groups then began to look at this in human babies and study this prospectively. So we have one of the groups from the United States looked at this in 26 infants, greater than 1,200 grams. They said this works. A group from Brazil looked at this in 48 babies, 28 to 35 weeks, and said this works. A group from Italy looked at this in 61 babies who were 29 to 35 weeks, and they said it works. A group from Iran looked at this in 70 babies who were greater than 2,000 grams and said this works. And then the largest study to date is this one that was published last year from a friend from Minnesota. And they looked at 103 babies. They randomized 103 babies to this. 28 to 35 weeks, greater than 1,250 grams. And they found a significant decrease in babies having to go on to be endotracheal intubated and then ventilated if they delivered surfactant through this laryngeal mask airway in this non-invasive way. So pretty exciting finding because there's an increased rate of CPAP success with this if we give surfactant earlier than we typically do when we endotracheally deliver surfactant. So they concluded in this paper that, this technology, this cheap technology, $1.63, is great for the high-resource neonatal intensive care units, but it is also great for places that don't have a high-resource neonatal intensive care unit. Those pediatricians that are on the first lines, that are doing everything in the community hospitals, who may at one minute be going to a delivery and resuscitating a baby and needing a tool to easily resuscitate that baby, and an hour later in their clinic seeing patients. And this is why this is so exciting, because we can use this tool in people who maybe don't get to endotracheally intubate babies all the time to help them resuscitate and then deliver that surfactant later so they can keep that baby at their hospital. Or if they have to transport that baby to a higher care facility, they're going to be able to transport that baby in a better state than maybe you would have previously. So this has the potential to significantly impact morbidity and mortality. So let's summarize some things before we talk about how to use this. So first off, the laryngeal mask airway is safer, it's easier to use, and it's least as effective, if not more effective, when compared to a bag and mask for ventilation. When it's in, you know it's in. It's also a very viable method for surfactant administration. Okay, you don't have to have the skills to endotracheally intubate a baby with the LISA technique. You still have to be a very skilled doctor to be able to put that feeding tube down the trachea to give the baby surfactant. With this, you don't. This requires minimal expertise and resources, and it avoids those adverse effects that we talked about and the patient discomfort that we can see with endotracheal intubation. All right. Let's talk about how to use this. And we'll go over this in more detail in the workshop this afternoon and tomorrow if you choose to participate in that. But here's some recommendations. Here's where you may want to get your phone out and take some pictures. I would make sure that you've at least optimized your CPAP to a +6, okay, to a PEEP of 6, to make sure you're using enough pressure to open the alveoli. The baby needs to be on oxygen of 25 to 30% for at least 30 minutes before you decide to place the LMA and go ahead and use surfactant at that point. Your weight, at least 1,250 grams. We're getting ready to start a pilot trial with a specially designed laryngeal mask airway that's going to be able to be used all the way down to 500 grams. So that's in the process of being designed, and it's going to have the surfactant coming out in a special place on that. So that's going to be important in the future. But at least at this point, with the current LMAs that are on the market, 1,250 grams, you need to make sure you've ruled out pneumothoraces and things like that, and the baby should have clinical signs of respiratory distress syndrome. And then you can repeat that surfactant every 6 hours if needed, if you still have an oxygen demand. So here's some supplies, at least it's showing up on this, but not on that. Uh-oh. No, just a picture. Oh no. Technical difficulty. Did it go? It's showing up on here, but it's not showing up on there. unplug it and plug it back in, see if that works. It's weird. Okay. All right, here's the supplies. Again, we'll talk about this in the workshop today. And I actually have some laryngeal masks for those of you that attend. I've got 2 for each person that attends that you can take with you. So simple little device that we use to administer the surfactant, just some IV tubing. You can also use some feeding tubing to put that down the laryngeal mask. A CO2 detector is optional, but that's one way to know that you have it in place. And then, of course, your surfactant. I'll also give you an algorithm that you can use and take home with you that goes through some of the high points on how to do this if you choose to do this in your hospital. But we'll talk about the laryngeal mask placement, how to insert that, how to insert it correctly, how that you know that it's in the right place. And then 2, how to go forward giving the surfactant, where you can do that in a safe manner before you pull that laryngeal mask and the baby is back on CPAP at that point. This is a video just showing this taking place in one of the hospitals in the United States. We're going to watch this in detail too in the workshop. I'm going to point out some things to you, some teaching points, so you can even adapt this to your own setting. And this is very easily adaptable to any setting. And I'm going to show you that in just a second. Over the past couple of years, I've had the opportunity to spend almost as much time in Azerbaijan as I have in Jordan. I've got a Fulbright grant with the U.S. State Department that allows me to go and spend time internationally with other academicians. And so I've been over to Jordan 3 times to work with the neonatologists at the Azerbaijan Medical University and neonatologists throughout the country. And 2 years ago, they told me they had a problem. They said, we buy surfactant for our neonatologists, but people out in the community hospitals are not using it. And part of that reason was that they didn't get to intubate a lot, and so they had sort of lost their skills and were scared, honestly, to do that. And so we got to, forgot to mention, I also was named Honorary Khan of Neonatology in Sheki. So if y'all want to bestow a title on me here in Jordan, then we can do that too. Just joking with you. But they let me go out to some of the regional hospitals in Azerbaijan, to Sheki and to Ganja, and then back to Baku, and teach this to their doctors there. So we taught over 200 Azerbaijani neonatologists and frontline pediatricians going to these deliveries, teaching them how to use the laryngeal mask airway for resuscitation and for surfactant delivery. And one of the great things about social media is people then send you their pictures and videos of doing this. So this is the first baby to receive surfactant by laryngeal mask airway in Azerbaijan. I had left the country like 5 days, and I get this through WhatsApp, which I thought was absolutely amazing. They followed my recommendations, and their very first baby was a 1,300 gram 27-weeker. And they had placed this laryngeal mask airway literally after only having done simulation in their hospital. So this shows you how easy this is to do, how really life-changing this can be for babies and for you as doctors on the front lines trying to take care of these babies and using the medications and supplies that your country buys for you. My understanding is that the Jordanian government also buys surfactant for the doctors. So this is great because, you know, what impact can this have in the healthcare system? In Azerbaijan, certainly, but in Jordan and other countries that we take this and teach this to use, because this is going to hopefully keep more babies with their parents, make babies better sooner, keep babies maybe at the community hospital so they don't have to be transported to some of these high-resource neonatal intensive care units, which was another problem Azerbaijan was having, that the babies were very, very sick by the time they made the 6-hour transport to Baku. So this can have the potential to decrease mortality and morbidity too, which is really exciting for a $1.63 device. So again, workshop today at 6:30. We're going to learn how to place this and use it for resuscitation and to deliver surfactant. I want you to simulate on a mannequin. I've got at least 2 laryngeal mask airways for you to take home for anybody that wants to attend. And then I want you to do me a favor. If you do this in your hospital, in your neonatal intensive care unit, in your delivery center, send me a picture and video, because this is something we're trying to begin to share. As I mentioned to you, I'm with a group of neonatologists that we're continuing to study this. We're trying to develop better devices to make this easier and easier for the international community. And pictures and videos and stories that I have that I can share with other people make this more effective. And it helps you see really how easy it is to do and how life-changing it can be for your practice and for the babies. Thank you.